Welcome everyone to Free to Breathe, a partnership for lung cancer survival, understanding lung cancer screening guidelines. This webinar today is brought to us with the help of our sponsors, including Boehringer Ingelheim and Genentech. We are very pleased to welcome you all today. Everyone on the line will be muted for the entirety of the call. We will be asking you to use the chat function of the webinar system in order to provide any questions throughout the conference. Today's presenters will be Christopher Slatour from Oregon Health and Science University and myself, Regina Vitiver. I'm the Executive Director of Free to Breathe. We're very pleased to have all of you here today, and we'll be discussing a few things today, including who should and should not undergo CT screening for lung cancer, recognizing some issues around screening, including anxiety, indeterminate nodules and false positives, some best practices for programs that are doing screening, resources from our organization, and of course, a question and answer opportunity. And just to let you know, Chris, our main presenter today, has asked that you go ahead and submit questions throughout the presentation, and I will be moderating those questions and engaging him in conversation as we go through the presentation. So please do feel free to put your questions into the chat function at any time, and we will have Chris address them both during and after the presentation. So with that, I'm going to turn it over to Chris.
All right, well, I'm going to see if I can make technology work for me. So Regina, thank you very much for inviting me. Hopefully people can see my slide now. Is that?
We see it on our end, Chris.
Okay, great. So I'm going to get started. So again, thank you very much for attending today. I was going to say coming, but that's maybe not the right verb in a webinar, but thanks for listening in. And as Regina said, definitely submit your questions as we go along. So what I want to talk about is the lung cancer screening guidelines that have recently been promulgated and who might and might not be applicable to those, and some questions that maybe individual people should ask. So the outline of today is we're going to just briefly talk about why we're going to reevaluate lung cancer screening now. We're going to talk a little bit about what the U.S. Preventive Services Task Force decided and why. And then we're going to spend most of the time what happens next, and then the questions you should ask yourself and your clinician when you're thinking about getting screened. And so one important thing to think about is the guidelines that we're going to be talking about are really applicable to groups, so populations of people, rather than sort of any one individual person. So there's always going to be caveats and other nuances when it comes to individual decision making. So again, so we should think about this in terms of testing big populations of people, and that'll sort of help guide our discussion today. So first of all, my guiding principle. With great power comes great responsibility. I don't know if people know who said that originally, but recently it's been attributed to Spider-Man's uncle, and so I think that's something that's out there in the community, and I think really helps guide me when it comes to screening, because screening by definition makes healthy people sick. So the whole point of screening is you take somebody who is asymptomatic, so doesn't have any symptoms of a disease, and you go looking for that disease in an early stage, before it's causing any symptoms, with the hope that by finding it early, you're going to change the ultimate course for that person. And so, so it's really, really, really important to remember that this is a huge power that the healthcare system has, and that patients are engaged in making decisions about. So that really helps. So always when we talk about lung cancer, it's important to sort of remember how big a problem it is. This slide here just shows the 4 overall leading causes of mortality in the United States. You can see that heart disease is number 1. Cancer, all of cancer is the second leading cause of mortality. But if you actually separate out lung cancer, so lung cancer is almost, actually is a little over a quarter of overall cancer mortality. It would, lung cancer by itself would still be the third leading cause of mortality in the United States. So again, as most of us probably know, a very very large problem. And it's also important to think about it this way. So screening, as we're going to talk about a little bit more, is really designed to for people at very high risk of getting lung cancer, and we'll discuss what high risk means. But in the group that's been best studied, and we'll talk about this study in more detail in a minute, 25% of overall mortality in heavy smokers was caused by lung cancer. And so lung cancer is actually the cause of death for a huge proportion of people who are at high risk. And so that's important when we're considering the different criteria for screening. So this is a list of things that when you're considering a screening test that need to you need to take these into account when designing a screening test. And these are sort of some general criteria that are espoused. So the first one, the condition should be an important health problem. So I think I just hopefully showed you that that's the case for lung cancer. There should be a treatment for the condition. So with lung cancer, there is treatment, at all the different stages of lung cancer, and there's good evidence that finding lung cancer earlier, the treatments are more effective. So there should be facilities for diagnosis and treatment. Those should be available. Again, we'll talk about that a little bit more, but you have to have a way to treat people, not just that you can, but actually, ways to treat people if you're going to screen for them. There needs to be a latent stage of the disease, and so what that means is there's a portion of the time course of the disease where it doesn't cause any symptoms, but by finding it at that early stage, there are treatment options then. Okay, so there needs to be, the fifth one, there should be a test or examination for the condition. So in our talk today, we're going to be talking about CT scans as that test. The test should be acceptable to the population, so it needs to be something that most people, or at least a large number of people, would undergo. The natural history of the disease should be adequately understood. This is less true in lung cancer. There are many questions about the natural history of lung cancer that are not understood, and so that we're continuing to do research on. And this actually is going to highlight some of the potential harms or concerns of screening that we'll talk about. And then there should be an agreed upon policy on whom to treat. Again, we'll talk about that later on. So why now? So before 2011, this study just shows that there's no good quality evidence that showed that screening for lung cancer worked. So there had been several studies looking at using chest X-rays to screen for lung cancer and preventing mortality, but those studies did not show a benefit. So up until 2011, it was universally recommended not to engage in lung cancer screening. But in 2011, a study came out that was very large and very influential, was published, and so the task force and many other organizations started re-looking at those recommendations. So as part of the U.S. Preventive Services Task Force job of making recommendations for various screening modalities, they ask different centers around the country to go out and look for all the evidence that is available about the question they want to ask. And so I was fortunate to be involved in the team that addressed this question for lung cancer. And so we went into this review with two main questions in mind. So the first, and probably most important, were how effective is screening for lung cancer in reducing mortality and morbidity. And so what the task force wanted from us is give us all the studies that have looked at this question. Okay? The second question that we looked at are what are the harms associated with lung cancer screening, and are there ways to modify those harms? And so again, those are going to be the sort of highlights of where we're going from here. This next slide basically just shows all the thousands of papers that we combed through. So we started with over 8,000 papers to whittle it down to the small list below. Again, there's no reason to sort of spend too much time on this, but except to say, hopefully convince you that we worked very hard to look under every rock to find every study that had ever been published in this area. But at the end of the day, most of the results and most of what we're going to talk about are based on this one trial that I alluded to earlier. And so that's the National Lung Screening Trial, the NLST, that came out at the end of 2010, and then 2011 was officially published. And so what this was actually the most expensive study that the National Institutes of Health had ever engaged in. I haven't seen recent numbers, but it cost $250 million, I believe, at the time this article was published. And so what this study did is they took 50,000 people considered at high risk of lung cancer based on their age, so they had to be 55 to 74 years old. They had to have a smoking history of at least 30 pack years, where 1 pack per day for 1 year is 1 pack year. And then they had to either be current smokers or recently quit within the last 15 years. And they had to have their health had to be good enough such that they could undergo the recommended therapy for early stage lung cancer, which is surgery. And so they took these 50,000 people and basically split them down the middle, and half the folks got annual CT scans, half the folks got annual chest X-rays. And so the first thing they found, illustrated on this slide, that actually screening found more cancers. Okay, so that's good. That's what we want. And so they found that low-dose CT had discovered a lot more cancers than chest radiographs. But the real question is, does doing that improve mortality? So that's what this next study shows. So this is the cumulative number of lung cancer deaths on this side, and this is the years since starting the study. Okay, and you can see that over time these curves start to separate. This curve here that I'm showing with my mouse is the folks who have received the CT scan, versus here's the curve for people that had chest X-rays. And you can see that at about a year and a half, those curves started to separate. And the fact that people who received the CT scan had a better mortality. There were more people alive at the end of their study period than were who had the chest X-ray. And in screening studies, we often talk about the number needed to treat. And so what that is that's a number that says if you were to screen X number of people, how many of those screenings would you have to do to save one person's life? And so in this study, they found that the number needed to treat to prevent one lung cancer death was 320. And I won't go into the specifics, but that's actually a lower number, and you can think of that as a better number than other commonly performed screening tests. So this was really what got people excited and really sort of led to the many recommendations to consider lung cancer screening. I'd put it another way, we want to look at how much what the change in benefit is for different groups of people. So in this way of looking at it, this sort of looks at it in terms of a group of 1,000 people. And so in the NLST, 18 people in the CT group died of lung cancer, okay? And in the chest X-ray group, 21 people died of lung cancer, okay? So what that means is there were 3 fewer deaths from lung cancer compared to the not screened group, okay, out of the 1,000 people. And again, that's an important number to know also, so that again, it kind of gives you a sense of what the overall benefit is. Okay. So what about other studies? There were 3 other studies that we found that really looked at this question. One of them was very poorly done, and there was really, in a sense, no definitive answer about the benefits of screening. Although overall they suggested that screening lower risk people may not be helpful. So again, talking about the risk based on their age and smoking history, it seemed that folks who had less risk of lung cancer weren't as helped. There's one moderately large trial going on in Europe, though I think it's unlikely to definitively change the recommendations, but it might point at better ways to implement screening. So those are the benefits of screening. What about the harms? And so one of the main harms of screening is really what this slide shows, is that of the people in the first round, so that's this T0 round, there were 26,000 people who had a CT scan. Over 7,000 of those people, so 27%, had a positive result. Now, it turns out later that if you look at this slide, and I'm sorry, it's a little blurry, only about 3.8, so 4% of that group actually had a truly positive result. The rest, almost 7,000 people, 96% had a false positive result. And so why is that? And that's because when you do CT scans, we find a lot of things that are potentially concerning for lung cancer. And so that's what this slide shows. So this is a CAT scan. For those of you who haven't looked at CAT scans before, I'll just sort of walk you through it. So this area here with the kind of gray with the white dots, these are the lungs. This white parts are bones, the other kind of grayish parts are muscle, skin, things like that. When we do CAT scans, we often see extra things in the lungs, and this is what we would call a nodule. So a nodule shows up as a white spot on a chest X-ray or a chest CT scan. And when it's very small like this, it's really impossible to tell at that one time whether that's something to worry about or something to not worry about. As we sort of alluded to before, most nodules actually aren't lung cancer, but a very small percentage are. And so when you first get this first scan that's just something like this, it's really hard to know if this is a lung cancer or not. Okay, so that's where a lot of the initially positives come up, but then later turn out to be falsely positive. Okay, and so this kind of leads us into the next section about talking about all the downstream side effects of having false positives. So this was a recent basically map, I guess is the best way to put it, of the potential harms of screening. So they call this the screening cascade because it kind of illustrates that screening is not just one CT scan, it's really the whole process of what you go through and the findings afterwards. You start here with a screening test, you get the results. It can be a positive test, true or false. You get a workup, and then you kind of move through this. Either it was a true positive and you get benefit from getting treatment, or it was a positive without benefit from treatment, or it was a false positive and you come back and go back to routine screen. So there's lots of different things that can happen after you get that screening cascade. But the way I like to think about it is a little bit more on a personal level. So this is a picture of my family. So this is my wife here and daughter here and our dog here. And I like this slide because it really reminds me of the screening cascade, partly because this mountain up here is Mount Hood, which is one of the biggest mountains in the Cascade Mountain Range where I live. And that also reminds me of how my wife and daughter convinced me that at some point we should get a dog. And I don't know how you guys feel about getting dogs, but I was a little skeptical at first because I hadn't had a dog before and I was wondering about it and sort of thinking about things. But they really convinced me that this dog would be nothing but benefit, right? That we were getting her for free, and she'd be great, and she'd get to go on these wonderful hikes with us and all this kind of stuff. And so we got we got the dog. She was free, and everything was great until one day she came down with a little bit of belly pain, unfortunately, and that led to a whole series of tests. So this is a picture of her ultrasound that she had, which I hadn't even despite being a doctor for several years now, I had actually heard of dogs getting ultrasounds before this, but it really sort of illustrates the cascade of events that can happen, and the somewhat unexpected cascade of events that can happen once you start down this screening path. And so the harms of screening that this group really wanted to talk about were the physical harms. So those are things like getting biopsies or surgeries, things like that are physically harmful. There's the psychological harms, things like distress and anxiety that are caused by being told you have a pulmonary nodule. There's the financial cost strains, so taking time off work to get extra tests, things like that. And then opportunity costs, things you would have done, but can't now that you're, sort of in this cascade of getting worked up for cancer. Okay? And this is another way to kind of put that, just to remind us that in this group of 1,000 people, 365 of them had a false positive result. Okay? 25% of those false positives led to an invasive procedure, and 3 people actually had a major complication from the invasive procedure. So again, just sort of pointing out that there are substantial risks to undergoing screening. In terms of the psychiatric or psychologic effects, we did some more work for the Preventive Services Task Force looking at this. We found that overall screening is associated with short-term psychological discomfort in many people, but overall did not overall impact distress, worry, or health-related quality of life. But it did appear that those patients with false positive results, there was a short-term increase in distress that returned to levels that were similar to those among people with negative results after about 2 years in the study that really looked at this the best. And then negative results were associated with short-term decreases in distress. But I think, again, this pointing out what distress is, and these are basically numbers on a scale that people had invented. And this next slide really just shows some of the potential distress that people actually go through. So this was a study that I was involved in where we surveyed people not with screening detected nodules, but incidentally detected nodules. And we really learned that both patients, first of all, didn't really understand what a nodule was, that some of the communication around that hadn't been ideal, and then also that there was a fair amount of distress as well. Okay, so I like this quote here, which I'll just read. Well, like I said, there's family history in there, so pretty worried. I'm talking about the nodule. I don't know what it turns into later or what it is, and they didn't show me the picture. Just so every once in a while, I'll lay awake at night and stare up at the ceiling. And so again, I think these quotes really, kind of bring home the point of the previous slide that finding a nodule, finding this false positive can really be quite distressful for some people. One of the other potential harms is this thing called overdiagnosis. So it's excess cancer detected by screening that would not cause death if untreated. And so we're sort of, I think it's relatively well known that this has become an issue a lot in prostate cancer. There's a lot of prostate cancer that we find by screening that would ultimately not lead to any problems. And it turns out that there's lung cancers that are probably the same way, either because the lung cancers themselves grow very slowly, or when you take a high-risk group of people who are older, like I said, for the screening ages up into their 70s and now even 80, according to some guidelines, who are smokers, have a high risk of dying of something like a heart attack or something like that. So that the fact that they're more likely to die of something besides their lung cancer. And so this can be a potential problem with screening. Because the problem really is that if you get diagnosed with a cancer, all of them get treated, even if it looks like you might have one of those slow-growing tumors, and then those treatments cause harm. And so there's this worry that, again, screening large groups of people will lead to not high, but rates of overdiagnosis. And so this, based on those data, the Preventive Services Task Force came out with a B recommendation. I'll highlight that here. At the end of 2013, actually, they released their final version of their findings on December 31st, 2013. And that date wasn't by accident. That's part of the Affordable Care Act requires that if the task force gives anything an A or a B recommendation, that health insurances have to cover it. And so within 1 calendar year. So within 1 calendar year, meaning by January 1st, 2015, lung cancer screening with CT scans will have to be covered. And then these are just a reminder of all the other groups that have recommended it. So the American College of Chest Physicians, the American Cancer Society, the American Lung Association, American Cancer Society, virtually all groups have really recommended lung cancer screening at this point. This is a slide just looking, again, just very briefly at how the lung cancer, or how the Preventive Services Task Force decided on the criteria they did. So they commissioned a group of actually 5 different groups around the world to do modeling studies to try to figure out what is the best group to screen, because the NLST criteria were people, smart people got together in a room and came up with these criteria, but they weren't evidence-based, and they really, just sort of thought, well, these people we think are high risk. So the modelers were really asked to say, well, is this really the group of folks that we want to do? And each one of these dots along this curve shows what would happen if we changed the screening criteria. And as you go up, that means the lung cancer mortality reduction goes down. So on this level, so you'd have overall a 15% reduction in lung cancer mortality. But you would have to, it would take 300,000 CT scans. This is in a group of 100,000 people to result in that. And as you go further out, you can see that this curve starts getting less steep. So again, to go from a 20% mortality reduction to say this is probably about a 21% mortality reduction, so very, very small. You have to go from 600,000 to over 900,000 CT scans. So again, that's at a very high rate of probably causing false positives and causing other sorts of harm. And so they looked at this. The task force looked at this curve and decided that the sort of best cut point was this one here. Sort of start at age 55, stop screening at age 80 for people with a 30-pack year smoking history. And actually, I'm so sorry, they used not this one. The one that ended in this one here, the one that ended at 15 years after quitting. And again, they I think quite honestly felt like, what is the right level to draw that line at? Is it here? Is it here? Is it here? I think well-meaning people, could, I think there could be lots of discussion about that, and they actually have that. So I think this is, what the recommendations are, but it's certainly not some magic number that this is the one true number that is the best. And you really have to look at it in terms of the risks and benefits. This slide again just shows how risks change. And so in the NLST group, they divided people up into 5 different groups based on how likely their risk of dying from lung cancer. And even within that pretty high risk group there, they found that this group here, the lowest risk group, who had less than a 0.55%, so less than 1% chance of getting lung cancer, they had to do a lot of CAT scans. So for every lung cancer death that they prevented, they had 1,600 CAT scans. And so thinking about that number needed to screen that I talked about at the beginning, they had to screen over 5,000 people to prevent one lung cancer death. So this just shows that even in that group, that there are different risk groups that may or may not have the same benefits, but often have similar risks of having false positives and the negative consequences from that. This slide is just a little bit of an interactive slide, just to kind of point some of that out, to kind of look to see how risks change with different different characteristics. And so this is looking at somebody who's the age of 65, who's white, who is a college graduate, BMI of 25, and who's smoked 20 cigarettes a day for 60 years. Okay, so that would be more than a pack a day, probably. They quit 5 years ago. So and then we kind of all these numbers spit out this number to say that this person has about this is percent, so 3.5% chance of getting lung cancer in the next 6 years. If you change that, which I'll do in another area over here, if you make the person 55, who's a lot younger, you say that instead of smoking for 60 years, they only smoked for 10 years. They quit 14 years ago. The risk goes considerably down. Like I think you can see now the risk goes to 0.3%, so a hugely lower risk. So this person is going to have much less likely chance of actually benefiting from lung cancer screening. And so I think this is really important to kind of look at these different risk factors and sort of with individual patients to help guide what sort of how to help choose lung cancer screening if it's right for you. And so what should a screening program look like? One of the guidelines, recommendations that put out there had some sort of thoughts on this, and they felt that a screening program should not just be a single CT scan, it should really be a whole system and whole program. So they felt that the counseling should include a complete description of potential benefits and harms. They felt that screening should be conducted in centers similar to those where the NLST was conducted, so those were highly specialized centers of lung cancer excellence. They felt that they should have a multidisciplinary coordinated care, and then a comprehensive process for screening, imaging, interpretation, management, findings, evaluation, and treatment of potential cancers. So really a whole system of primary care people, radiologists, pulmonologists, medical oncologists, thoracic surgeons, everybody that's really involved in taking care of lung cancer, really having a whole system to best take care of people. And then also, remark number 5, when this group was screening for lung cancer is not a substitute for stopping smoking. So really wanted to emphasize that if someone is a current smoker, probably the most important thing they can do is to stop smoking. So questions I think you should ask when you're considering screening. This is what I tell my patients that are in front of me. So what are the benefits and risks for you? Again, thinking a lot about that example we just went through. To sort of think about what are your risks and what are the likely benefits to you? How will you feel if you have an indeterminate result? I think a lot. I've definitely had patients who feel it's better to not know. They feel that if I got told I had something that might be cancer, but probably isn't, but the best treatment is to just to watch and do another CAT scan down the road. That would be too much stress to live with, and so I'd rather not know. I definitely have patients that tell me that. How would you feel if you decided against screening? So if you're in that group, but then in 3 years you were diagnosed with an advanced lung cancer. And again, I think that's really a personal decision. If your doctor recommends watchful waiting, so again, like you get a initially positive result, how are you going to feel about it, living with a potential tumor in your lung? And I think that's really important because I think a lot of people, that's very, very hard to do, whereas that's most likely overall the right thing to do. It can be very hard and very distressful. And so thinking about what your reaction is going to be is important. And then I think it's super important to ask your doctor about who's involved in the lung cancer screening program. Again, sort of with that idea with the guidelines about making sure that there's a whole system of care in place to help take care of you. And so again, getting back to the guiding principles, hopefully I've convinced you that screening is a great power and that we need to have great responsibility. And then I think that even more so in screening, and the way lung cancer screening is, there's a lot of unanswered questions about what is this going to look like in the real world, and how do we implement the best the highest quality screening programs? How do patients react? What procedures are necessary, and which ones may not be necessary? All these things are very much unanswered questions now, and so I think it's really important for all of us to remember that as we embark on this lung cancer screening. So in summary, I think lung cancer screening using low-dose CT scans is now widely recommended for people at high risk of developing lung cancer. Screening will, again, I put in parentheses hopefully because it did in one randomized trial, but we really need to see how it works out in the real world. And we know it will cause harm, based on the things we talked about. So wisely choosing the right person for screening at the right time is critical if screening overall does more good than harm. And think about how you'll react to CT results and strongly consider multidisciplinary care. And so that is it for my slides.
Thank you, Chris. I'm going to just give just a few things here from our end at Free to Breathe, and then we're going to open it to all of the fabulous questions that have come in.
Okay.
So just a few things to let everybody know that at freetobreathe.org/screening, we have an overview of these guidelines. Try to describe what CT screening is for somebody who doesn't have the background there and is wondering about getting screened, and what to do if something is found and where one can go for screening. There is a downloadable fact sheet that folks can take with them to a doctor's office if they are interested in screening and that has not been broached by the physician. They can give it to eligible family and friends. They can print it out for libraries, health fairs, etc. And there's this fabulous infographic that is there to help people remember who is really the eligible group that we're talking about with these guidelines. Obviously, if something is found on a screening approach and it does turn out to be cancer, we have an entire suite of resources available for the person who is diagnosed at our website at freetobreathe.org/lung/cancer/info. And just to give you a sense of these, there's some graphics here to show you what they look like. All these resources are available online. They are available for free to have print copies, to download, and they can be ordered in quantities for medical clinics, for community outreach, etc. Once again, I would like to thank our sponsors who have made this webinar possible, Boehringer Ingelheim and Genentech. And I am now going to pass some questions along to you, Chris.
Oh, great.
So one of the questions that came in is, what physicians are actually on the front line of prescribing screening?
Well, so that's a great question. And quite honestly, as it gets rolled out, that'll probably change. right now my sense is that it's oftentimes either a radiology group or pulmonary group that's kind of leading this. But I think eventually it's really going to need to be one of the tools in primary care people's armamentarium. I think it's going to be very similar to the other cancer screening tests that we do that really start in your primary care provider's office. But how that works in the real world is really it's really not known at this point, and I think that's one of those unknowns that people like me and lots of other folks are really trying to research and really understand how that works and how that works best.
Great. And if somebody is a physician is involved or another allied health professional is involved in a screening program, considering that we're talking about people who are considered high risk, which is defined in this case as people over the age of 55 with a 30-pack year history of smoking, how many patients might someone wind up sending a month for screening?
That's another super good question. There are estimates about that, and so the NLST estimated that about 7 million U.S. adults would qualify based on their criteria, which were a little more stringent. In some of the modeling studies that the task force used, it was up to 19% of not total adults, but a sort of a pretend cohort of adults of people born in 1950. So it's probably somewhere, my guess is in the average primary care clinic, it's probably 5 to 10% of a general internist cohort. In the VA, we're studying this question, and right now it's looking about like 20% of our patients going to a primary care person might qualify. So I think it really depends a lot on sort of what setting you're in. But it's going to be affect a lot of people, I think, is the sort of bottom line.
Great. And there are a number of questions about other risk factors besides smoking. So whether we're talking about family history, exposure to radon or other agents, and how that may or may not have been taken into account with the guidelines.
Yeah. So those are also really good questions. So some of those were taken account in the models, at least, to sort of look at lung cancer risk. And although this isn't a recommendation, because the task force really didn't have enough evidence about this at the time, certainly some people would say if you plug yourself into that into that spreadsheet that I demonstrated, and based on a family history or one of those other factors, if your risk is as high as somebody who otherwise has an equivalent smoking history that would get qualified, then maybe you should consider that on an individual basis. And that's in terms of the things that they looked at. Other risk factors like radon or asbestos exposure, or how much which relatives in your family were that were affected by lung cancer. It's really hard to know. It's really hard to quantify those risks in a large way. And so what my personal recommendation would be is if you have one of those risks yourself, I think it's really important to talk to your either primary care person directly, and or talk to somebody who's maybe an expert at lung cancer screening about the potential risks and benefits for you. But it's probably never. It's unlikely that is going to be part of a overall recommendation until we have better evidence of the potential benefits in those groups who have high risks for reasons other than smoking and age.
And then, Chris, there were a number of folks who wanted to know how they could have access to that interactive risk predictor that you showed, and where that's from.
It's on the web. I don't know if I have. Am I still sharing my slides?
You're not, but we can. What we can do is we can send that out, because I do know where we can find that reference and make sure we have it.
There's a website, and I can get it to you. If you Google lung cancer risk prediction, it might show up. I think it's from the University of maybe Toronto, I think, and it's free. You have to sign some agreement that I can't remember, that you're not going to publish it somewhere else or do something else. But I think anybody in the public can look at it.
Awesome. And then there were some questions about sort of getting a baseline CT scan even if you don't fit in those quote-unquote high-risk areas, just so that you would know if you needed a scan for the future?
Yeah. I don't think there certainly isn't any recommendation to do that, and it would be hard to know what to do with that information. So I think most people would recommend not getting that.
And then there was a question about what are the procedures that are actually used to determine if a nodule is cancerous or not?
Yeah, that's a great question. No, not, and the main one that's used is just follow-up CT scans. So the vast majority of the nodules we find in screening are very small. And so they're so small that you can't really do any other tests that would work to tell what they are. So the most common test is a repeat CAT scan, say in 6 months, because if it's an early lung cancer, chances are that within that 6 months or a year timeline, it's going to grow a little bit, and so that'll make you more concerned. And if it doesn't grow, then you're much less concerned. For nodules that get a little bit bigger, there are several other tests people can do. So in nodules over about a centimeter, then PET scans become a viable option that can sometimes help determine if it's cancer or not. As the risk goes up, you can consider doing biopsies, which are either done from the outside in with sort of using a CT scan to help guide where the needle goes, or from inside in, which using like a bronchoscopy, which is a small camera that goes into the lungs and can find the nodules. And probably the best way, and most appropriate way in most screening settings, is to go directly to surgery. So these other biopsies, they're often, if it turns out that if you get a biopsy of a nodule and it turns out that it's cancer, then you're going to recommend surgery to cut it out. If you get a biopsy that doesn't show cancer, that's actually oftentimes not that reassuring, because the biopsy technique and what we can get out on a biopsy is not 100%. And so usually then we would recommend going to surgery anyways. So oftentimes the best way to treat a kind of high risk but still indeterminate nodule is to go directly to surgery. But I think those would be questions that you'd want to sit down with and talk to your a team about. And that brings up the point that really it's screening needs to be done in sort of a team setting, so that you get the surgeons who do the surgeries to cut these out to really weigh in to see if surgery is the best option, or if you have the pulmonologist there thinking there's some other thing to do, and it's really important to have all those different sort of disciplines of people think about it.
And Chris, there was a question about what is the smallest size nodule that can be seen on a CT?
Probably about 2 millimeters is probably as low as you can see on the kind of CT scannings that we're talking about, these low-dose CT scans.
And then what's the size that then starts to be something considered either watchful waiting or higher risk and wanting to do something more invasive?
Yeah, so there's a series of recommendations that are based on the size, and so I don't have those memorized right in front of me. But one of the main cut points is that if it's bigger than 9 millimeters, so if it's bigger than 9 millimeters, that's when we sort of start talking about PET scans or biopsies or surgeries or things like that. If it's less than 9 millimeters, we almost universally recommend serial CT scans, and depending on how big, we'd recommend usually either a CT scan 6 months from the previous one or a year from the previous one. And we base that just on the likely rates of lung cancer, or likely rates of growth of lung cancer. So it turns out if something is very small, even if it doubles in size, it's still going to be very small. And so it's really hard to see on a CAT scan unless you kind of give it enough time to grow appropriately. So for instance, if you start out with a 4 millimeter nodule, if you get a CAT scan in 3 months and it hasn't grown, that's actually not reassuring at all, because even under the sort of most aggressive tumors, you're not going to see grow in that short amount of time and with the resolution we can achieve on a CAT scan. So it's really important to consider what the recommended timing is.
And there was a question about, in the NLST, what the stage distribution was with X-rays versus CT scans. So obviously when we're looking at a screening program, we want a situation where we're seeing people being diagnosed in an earlier stage of the disease. So there was a question specifically to that study.
Yeah. So they did, I don't have those numbers right in front of me, but yes, they did see more earlier stage disease than late stage disease. And whoever asked that question, that's a super important question, because you have to have that in order for screening to be successful. Now, it doesn't prove, just because you have that, doesn't prove that it's going to change mortality, but that's certainly one of the criteria you have to have, and NLST has seen that stage shift that we call that.
And what are the risks of serial radiation?
In terms of causing lung cancer itself?
Or anything else?
Yeah. So in older people, it's probably not. So the short answer is it's not very risky to get these sort of low-dose CT scans. Again, that's why that's the part of the low dose that's important. If you're younger and a woman, your chances are higher of getting either lung cancer or breast cancer, probably. So that is sort of a risk that is there. The modeling group that helped inform the task force looked at that, and at least in a modeling way, to sort of say, well, what do we think, how many lung cancers might be caused? And it was a very low number, but it certainly wasn't zero. And so it is a concern. Probably overall, if I had to say, I'd say it's a small concern, but it's certainly a concern that we need to talk about. And again, is another reason why you only want to screen people who are at very high risk of the disease, because otherwise, if they have little chance of benefit, then they're more the harm becomes more important to consider.
And then there was a question about the rate of false positives in CT scans for lung cancer versus other types of screening, so whether we're talking about mammography or PSA or anything else. Yeah,
no, it's a very similar kind of issue. So, it happens with all those sorts of things. One of the problems with lung cancer false positives is that there's, unlike oftentimes false positives with mammography or PSA, or with PSAs, you can sort of figure out much quicker if it's actually a false positive or not. So the problem with CT scans, like we talked about, is you often find these things that you can't, there's really no other test except a CT scan 6 months from now. And so that can be very stressful to have to wait, that 6-month time frame. And then also the risk is different because the procedures are different. So as you can imagine, having, say, a lumpectomy from a breast surgery is overall much less, it's a much safer surgery than it is to do lung cancer surgery, where you open somebody's chest and have to cut out a fairly big piece of lung. And so the risks of those the therapies we use to diagnose lung cancer are much higher in this setting also. So there certainly are similarities, but there are also important differences that people need to think about.
And then on the opposite side of that, there was a question about whether you can have false negatives.
Yeah, and so that's another. It's really hard. We tried to quantify that in our review, and it turns out it was pretty much impossible, because everybody defines a false negative differently. So it really is hard to know, but it's certainly possible that you can have the kind of lung cancer that is so small that you're not going to see it on your your CAT scan you get today, but is growing fast enough that that it'll be there on a CAT scan in a year. And so that sometimes would be called a false negative. But it's an important thing to consider, but it's hard to really quantify how much to worry about that.
And then, Chris, there's been questions about other methods, whether we're talking about screening or risk assessment by using molecular methods.
Oh yeah, that's another very hot topic. And so today there aren't any other methods that we can use for screening besides CT scans. but there's a ton of interest in it, and a lot of people who really want to figure out, are there other, either adjunct tests? Can we, if you get a CT scan and you have a 5 mm nodule, is there a blood test that might tell, okay, that, most of the time that 5 mm nodule is not going to be lung cancer, but is there another test, we can do at that point that'll change that chance and say like, oh, you have, XYZ is positive, so that means even though it's a 5 mm nodule, it has a much higher chance of being a lung cancer, and so maybe we want to keep closer eye on you, or actually do surgery sooner than we, usually do, or, vice versa, is that test, that XYZ test negative, and that makes it so that there's really almost no chance that you have, that this 5 mm nodule is lung cancer, and we can not do, more CT scans on you. So I think those things will be in the pipeline, but none of them are ready for prime time use.
And then there was an interesting question about whether some people who get a CT scan, if they are in that, continuing to smoke category, if they would, upon getting a negative scan, say, oh, well, then I can keep smoking. And how would you prevent that?
Wow. These are the super awesome questions. That is a concern. It didn't look like that so much in the studies we reviewed. It seemed that people with a positive result quit more, but it didn't seem that people with a negative result quit less. So that makes sense. But it's a super important point to talk about with between if someone's an active smoker, and to talk about that with their clinician. And again, I think it's really important to say that just because you don't have lung cancer today, that's great, but you're still at by continuing to smoke, your risk is continue to be very high, and using every opportunity to try to help people quit smoking with and offer everything we can to help is going to be important.
And then, Chris, there was a question. You had a lovely infographic that you were showing different close-ups of, and folks are wondering where they can access that.
I don't know. So that's something we've developed here within the VA that I don't think is ready for primetime use that we can sort of send out. But there is, again, there's on the National Cancer Institute website, they do have a semi-similar graphic that kind of talks about that. So if you Google National Cancer Institute lung cancer screening, it'll take you to that page. And there's a really nice handout that kind of goes through some of those risks and benefits. It's not quite as pretty as the one I showed, but I think it's pretty effective.
Wonderful. So we have, I think most of the other questions that we've gotten to, there was a question around, the other questions have really been more around somebody who has cancer and they have no evidence of disease now, how frequently they should be screened after that, which is obviously a very different conversation than primary screening.
Yeah.
But I don't know if you can address that at all.
Well, so it turns out that I was on a different review that looked at that question for the American College of Chest Physicians. So sort of by chance, I know a little bit about that question. But it is really important that that's not screening anymore. That's surveillance, and those patients like that were not included in the NLST. There are some patients that are included like that within the other ongoing trial that I briefly mentioned, and so we might have some more information about those groups when that study is published. But for right now, there really are no good data to tell us what to do about people who are in who don't have evidence of, have been treated, had curative treatment for their lung cancer, and now don't have evidence for diseases. How often should you look for that? So I think the American College of Chest Physicians made some recommendations, but there, quite honestly, there aren't any good studies that give us great information about what to do. I think most people seem to be getting CAT scans on probably a yearly basis, and that's probably reasonable. But there aren't data to say how reasonable that is. Should you do that in everybody? All kinds of questions that remain to be answered in that area. So it's a good question, but unfortunately we don't have much information to answer it.
Yeah, and I'll just add my own take on that. Is very similar to what you talked about in terms of screening. Is the person has to feel where is their anxiety level going to be,
Yeah.
and if their anxiety level is going to be through the roof if they don't get a scan every year, then they might want to continue getting a scan every year, even if they pass that 5-year survival mark, and the doctor doesn't want to do a scan anymore. So really, it does have to be that individual conversation between the person and their physician to do what's really best for that person. That's my perspective.
Yeah, no, I think that's a super good perspective, and I think that's right for all these decisions. Is that again, you can talk about these in sort of the aggregate. But every one of these decisions needs to be made at a personal level. Between the patient right there who's making that decision.
All right. Well, I'm going to take 2 more questions and then we're going to wrap up. So one question was around as we move from the very constrained place of a randomized clinical trial to moving into now actually screening the population. How do you think that the data will change in terms of the benefits of screening as we go into a more diverse population that may be less fit for surgery, things like that?
Yeah, that's again out of all amazing questions. That one's super awesome. We don't know, so we really need to keep doing research in this area because I think that question really hit on a lot of those things. How do we select the right people? How do we make sure patients get high quality care? All those things are really completely unknown at this point, but super important to consider because like we sort of showed, if we screen people who are at very low risk, we have a good chance of causing more harm than good, and if we screen people who can't get the best treatments for lung cancer, like surgery to cut it out, then we may end up doing more harm than good also. And if we do more biopsies than they did in the NLST, that then lead to more complications, we can cause more harm than good. And I think you can see from those pictographs that I showed that the sort of seesaw of where the risks and benefits are is not. It's kind of in the middle, right? I think there are some fantastic benefits, but also some serious harms, and so it's not going to take a ton of harms to push that over to make it more harmful than beneficial. So I think we need to keep studying this issue and go back and forth and really try to answer some of these questions. Again, we've seen in mammography and prostate cancer screening that's been going on for decades, and we still haven't figured out, everything about those screening tests. So I think lung cancer screening, hopefully we can learn from some of the things they've done right and some of the things they've done wrong in those settings. But I really think we're going to have to continue to try to answer those important questions.
And then just for the final moment, we've been talking a lot about patients who are fit for surgery, and there was a question about what about newer approaches in radiation therapy as effective uses for treatment, even for early-stage patients.
Yeah, so I think that's a good question, too. So certainly in the NLST group, it was fairly well written into the study that you had to be eligible for surgery. So moving outside patients who may not be eligible for surgery, I think those is really sort of, again, a black box that we don't really know. There's probably some of those patients, they're not fit for surgery because they have bad heart problems and bad lung problems. Some of those patients probably wouldn't benefit from finding lung cancer, tons early where it's still asymptomatic, just because, like we talked about with the overdiagnosis part, those folks may be at much higher risk to die from something else, and so, may not benefit. We don't even really know how some of these newer, mostly like radiation therapies compare to surgery. There's some evidence that suggests that it may be close to some surgeries, and other evidence suggests it may be much less beneficial than those surgeries. And so we really don't know how those sort of newer therapies are going to impact the potential benefits with screening. So again, I think that's another question that's going to have to be looked at as we move forward.
Well, I'd like to thank Chris in particular, and I would like to thank all of our participants. You've been outstanding at giving us fantastic questions.